This is the Tox Course Podcast. Welcome back to the Tox Course Podcast. In this episode, we delve into a relatively uncommon but quite serious and important topic in emergency medicine and toxicology, and that is body packers and body stuffers. Body packing refers to the smuggling of illicit drugs into a country inside a person. In contrast, body stuffing refers to someone who is carrying a quantity of illicit drugs, usually a dealer or a recreational user, who, whilst in the process of being apprehended by law enforcement or security guards, panics and swallows all of the drugs they are carrying in order to avoid them being detected. This is the first of 2 podcast episodes on this subject, and these were recorded as part of Module 2 of the Tox course, which you can access at etmonline.com. However, we felt that the information in these sessions was so valuable that we would share them for free on the podcast. In this episode, we discuss body packing and share valuable clinical and medico-legal insights that you will definitely find useful should you be involved in one of these cases. In the next episode, we talk about body stuffers, how they present, and the challenges of caring for a patient who has found themselves in this situation. It's the sad reality of modern life that demand for and consumption of illicit drugs continues to grow, particularly in countries like Australia. This means that international drug cartels will use any means at their disposal to import drugs into a country, and one method of doing this is by paying people known as drug mules to swallow dozens of small sealed packets of illicit drugs, get onto an international flight, enter a country, and hopefully make it through customs before they start passing the packets out of their gastrointestinal tract. However, some of these people will be detected and arrested by customs officials at an immigration checkpoint, usually at a large capital city airport, and will then be brought to hospital for confirmation and quantification of the drug ingestion. Obviously, the amount of drugs ingested are massive and carry significant risks to the person who has ingested them. Should any of the packets or parcels that they've swallowed perish or leak, the potential dose they will be exposed to can cause significant toxicity and, in severe cases, death. So we'll now jump in with the creators of the Tox course and my co-presenters on the Tox course podcast, Ingrid, Berling and Nick Dafters, with the lowdown on body packers.
When we use the term body packers, we're referring to people who have specifically packed multiple small packets of drugs in an attempt to bypass a border control of some form. These are people who we often refer to as drug mules, and they have large quantities of small packets ingested in their abdomen. And whilst these are well-packaged packets, they are huge quantities of drugs. So the risk of leakage may be relatively low, but the risk of harm is significant if one of these packets was to leak. Andy, you work in an inner city Melbourne hospital. Is this something that you routinely see in your emergency department?
Look, it's a thankfully really rare presentation, but as mentioned, it can be really serious, not only from the clinical and toxicological perspective, but it's also a really serious medico-legal issue. These are people that have been usually arrested at a border entry point, so usually at an airport, and they're often, as you said, potentially part of a much larger scale international drug syndicate operation. So this draws the interest of the federal police as well as the border force in Australia. So these are really serious cases on multiple levels. So when these people present, it's worth remembering that, look, they're under arrest, they're not going anywhere, they're in police custody and they will remain so throughout their stay in your ED, and regardless of the outcome, they'll be discharged back into police custody. Even if you don't find any drugs, they will still be going through that process for police processing. So the police will be heavily involved. It's worth remembering that most states and territories in Australia have a designated hospital that deals with these patients, that has a relationship with their local airport, and they're the designated place where these people will get caught. And these hospitals will usually have very standardised policies and procedures on how to handle people who have been deemed at risk for body packing. If you work at a hospital where you don't routinely see these patients, or you've never seen one before and it's not the main centre, I'd strongly encourage people to find out which hospital is your state centre for this and liaise very closely with them. They'd be able to send across their guidelines, policies and procedures and give you a lot of direct advice on how to handle this, because it's quite complex. If, again, a patient who you was suspected of body packing is brought to your hospital, because of the medico-legal implications, you'd also be very wise, I think, to involve your emergency department director, just at least with a phone call, to let them know that a patient in this situation is being brought in. And this may actually escalate right up to your hospital executive and or your hospital legal service, just to make sure that these cases are handled properly from the legal side of things. Obviously, our focus as clinicians is the clinical aspect, but there's a lot of overlap in these cases. Also, you may actually want to involve your state toxicology service because of the clinical risk, particularly in a patient who is showing any signs of a toxidrome or any suspicion that a package has leaked. These patients can get really sick, potentially end up in ICU level care, potentially need surgery. It can get quite complex, and you definitely want to let your state tox service know. With regard to consent and treating these patients, we also have to remember that we can't force treatment on these patients, despite them being in custody and under arrest and not going anywhere from the police perspective. We can't force them to be examined, have treatment, undergo any investigations without their informed consent. Thankfully, again, because it's such a well-recognised problem and there are established protocols, nearly always patients will have signed a medical release or a consent to treatment and imaging form that the police have before they arrive at hospital. If you find yourself getting into a situation where the patient is refusing to accept your treatment or investigations, then you would definitely escalate this to the most senior people in your hospital, and don't have that interaction with the police and the patient yourself.
Thanks, Andy. So, Nick, if you did have a patient like this present to your emergency department, what would be your first approach?
Yeah, I think the first thing that's worth remembering is to have a compassionate and ethical approach to these patients, and remembering that in many cases they may be completely involuntary. They've been forced into this situation by criminal activity, essentially, and there has been pediatric cases of drug mules. So I think if we start from that point, and then I think there's a really important decision node when you first approach these patients, and there's two different types here. One is a patient with any sign of early toxidrome is a clinical emergency, and they're going down a very different path to the stable, well patient with presumably intact packages inside them. So if you recognize that the patient's got any hemodynamic instability or an evolving toxidrome, that would be a straight to resuscitation area case. Ideally, you're going to involve early with your toxicology service, and these patients can get very unwell very fast with a high mortality risk. So treatment would be everything supportive up to and potentially including surgical intervention and occasionally laparotomy to remove the packages to prevent a bad outcome. The second tier are the patients who've got no signs of actual drug effect, but we are known to be or suspected of harboring significant packages. In that case, usually the first go-to step is an imaging process. And that the recommended imaging, to my understanding, is usually a low-dose CT, similar to what we might order for renal colic these days. Is that the most evidence-based investigation of choice in this context?
There's definitely a lot of published literature on the specificity and sensitivity of X-ray and CT in the body packer scenario that supports that CT is very sensitive and specific for this situation. So we would generally go with a low-dose CT as you've recommended.
My understanding is the CTs are quite good, and you are sometimes able to accurately count the number of packages, but if there's multiple packages, it can start to get a bit unclear because you have overlaying, packages, and the total number can be tricky to ascertain. So you can't rely on 100% to count the packages as they come out and be 100% sure that they've all passed without sometimes re-imaging. Is that fair?
Yes, the sensitivity and specificity for a negative CT would be very reassuring. And obviously, a positive CT is going to put you down a treatment pathway. But the exact number of packets, especially if we're talking over 10 packets, is not guaranteed. There's been cases of people that have had significantly large numbers of packets in their abdomens doing this sort of thing.
There was a recent high-profile case in Australia where I think the end count was something like 127 packets of cocaine that someone had ingested. Also worth remembering that these patients, due to the duration of their journey, they've often come, if they're coming to Australia, they usually come a long way from overseas. They may have actually passed some of the packets and re-ingested them. So if you see some packets, don't just focus your view on that part of the scan. You can have packets the entire way through the gastrointestinal tract. And also worth remembering that sometimes patients will stash packets elsewhere in their body. So small packets can be hidden in the mouth or under the tongue, sometimes under skin folds, and some patients will tightly wrap small packets and put them into other orifices such as the anus or vagina. So when looking at the CT scans, as you said, if they've got large numbers of packets, you can imagine on a CT they'll be overlapping and hard to discretely count each individual packet. But one small trick I've heard is to put the scan onto lung window. So it's like a CT KUB. It's already sort of low res, and that will highlight foreign bodies and air in the GI tract. And then if you switch it over to a lung window, that will also highlight packets as well and potentially make it easier to count them.
So, Nick, a patient does present to emergency department and they have a CT that shows that they've got multiple small packets in their abdomen and they're asymptomatic. What would your management be from here?
First of all, I would absolutely refer to any local guidelines that were relevant to my jurisdiction, because there'll almost certainly be some that would be relevant, and that will help guide what level of ongoing follow-up this patient's going to have. Generally, these patients need to be admitted so that they can be observed while the packages pass. Most of the time, these packages will pass naturally through the GI tract, and then someone needs to be looking for these capsules and packets within the passed stool of the patient. Now, it's quite clear in most guidelines that that's not a healthcare worker role. We have to remember again that there's a forensic component to this, and the chain of evidence is important. And it's very easy to breach the chain of evidence in a legal fashion by having someone that's, it wasn't clear if the packages came out or perhaps had been flushed. So in certain settings and in customs or prison settings, they have toilets specifically designed so that things can't be then flushed down the toilet. In the hospital setting, it would be the job of the Australian Federal Police, most commonly, to look for these packets, count the packets, and save them as evidence. So we need to be really clear what our role is there. Obviously, there's situations where unfortunately the packages aren't passing, and I believe many of the protocols contain pathways whereby you can try and accelerate the bowel transit time, trigger some diarrhea, often with osmotic laxatives, to try and accelerate the release of these packets. So drugs like Movicol. Suppositories are to be generally avoided because there is some rationale that they can breach the lining of the packets and cause a leak. Is that fair in your understanding?
Yeah, this would be what we would refer to as whole bowel irrigation in the toxicology world, often with the use of multiple packets of glycoprep. And I think you would be seeking some expert advice at that point.
I have also heard of cases where you can have obstruction because of large numbers of impacted packages. So I think in any situation where you're observing a patient in a clinical scenario and the symptoms start to change, or abdominal pain develops, or the patient starts to vomit, all the usual things we'd look for in the context of an obstruction, that's a different clinical scenario again, and then you'd be re-referring the patient and involving your surgical services in the first instance.
Thanks, Nick. So, Andy, what toxidromes would you specifically be watching for in these types of presentations? And what would you do if the patient started to become symptomatic?
So the two commonest drugs that are ingested for these sorts of operations are cocaine or symptomimetics, sometimes methamphetamine, and heroin. So they're the two main toxidromes you'd be looking out for. So a stimulant toxidrome or an opiate toxidrome. And that would imply that if they're not getting a surgical complication such as a bowel obstruction, the patient starts getting worse, getting abdominal pain, and their vital signs start changing, they start looking unwell, that's what you'd be on the lookout for. And that then puts them down a different pathway. And just to highlight that point, sometimes these patients are kept in emergency department short stay units because we are capable of doing the forensic side of things as well as the toxicological observation side of things, rather than an inpatient ward where you can imagine the patient might not be being watched so closely. So it's important that we check these patients every hour, or they have 2 hourly obs, for example, while they're being observed, while they're passing packages. And should they start to develop a toxic looking picture, then they are going down a different pathway. They're no longer just there to pass the packets and leave with the police. This absolutely implies that the packets, at least one and sometimes multiple packets, have ruptured, and this person is now potentially going to become very unwell. So this would trigger a few things. Obviously, you would treat the toxidrome as you would for anyone who'd ingested these substances. So if it's stimulants, it's going to be benzodiazepines as your mainstay. If it's opiates and they're becoming sedated or obtunded, you would start giving naloxone. and be guided by your tox service around doses and quantities and endpoints for that. However, it also, because this implies that a packet has ruptured, this really triggers a surgical emergency that the packets need to come out immediately, because if one's ruptured, multiple may, and the person can die very quickly. Generally, endoscopy is not recommended as the method of removal, partly because they won't be accessible, because they're often traversing the whole length of the small bowel or the very proximal large intestine can be just hard to access, and also because there is a risk of rupturing the packets with the endoscoping, causing the patient to deteriorate further. So unfortunately, if a patient is showing signs of a packet rupture, they will usually end up in the operating theatre having a laparotomy and having these packets removed manually by an open procedure into their bowel.
Absolutely. Once you've got any sign of a toxidrome happening in this picture, you have a time urgent emergency in front of you, because the amount of medication or illicit substances that are in that person's abdomen are a life-threatening dose. So, Andy, you had one of these packers present to emergency department. You've observed them. They've had no toxidromes develop. What would be your discharge criteria?
So your discharge criteria for these patients are that you want to make sure they're clinically stable, they've had a period of observation, 6 to 12 hours, assuming that some packages were found on the CT scan. You want to ensure that they've passed all of the packages. If you're able to count them on the scan initially, and you've got an accurate count for the packets that have been excreted and that matches up, and you've perhaps double checked that with your radiologist, double check it with the police that are counting them, and everyone's happy, then the patient can leave. If there's a discrepancy or it's not clear how many packages have been passed or how many were exactly on the initial scan, it's fairly routine for the patient to undergo a second and occasionally sometimes a third CT scan, remembering these are low-dose scans, to confirm excretion of all the packets. So if the packages are all excreted and the patient's clinically stable, then they can be discharged into the care of the police. Also worth remembering that these patients will be discharged into the care of the police. They're going back to an observed custody area. So should they become unwell at all, they'll be able to fairly rapidly be returned to the ED for a review.
Yes, and I guess if we're talking about packers who have potentially hundreds of little packets in their abdomen, then the length of stay in hospital could be quite long, 48 hours.
It would be 12, 24, 48 hours, depending on the process, depending on their willingness to accept whole bowel irrigation. Some patients will refuse, in which case you've got to sit there and wait longer. If they take it, it might expedite it. But again, it's going to be very variable depending on their transit time, the number of packets, and their clinical status overall. So there you go. That was the deep dive on body packers. I hope you found that useful. I work at a hospital that is one of the nominated places where people who find themselves in this situation get taken. I can tell you from first-hand experience, it's a really challenging situation to find yourself in as a clinician. But hopefully, if you have a body packer present to your ED, the tips we shared in this episode will be of some use. Also, please remember that the person presented to you as a potential body packer represents a very, very small cog in a very, very large machine. There's a high probability that they found themselves in this situation as a result of coercion, and they are very likely a victim of a criminal enterprise. Whilst they will be charged with a criminal offence, and it is good that the drugs they were carrying will not end up reaching end users, the overall impact of this seizure on the total quantity of drugs imported into the country that year, and the impact on the organisation they work for, is almost non-existent. These people are considered disposable if they are caught, and the amount one person can carry is a negligible percentage of the total quantity being imported each year, so please treat them with some empathy and compassion. As mentioned in the next episode, we'll get into body stuffers, who represent a slightly different population of people who swallow large quantities of drugs. And Nick and Ingrid and I will do another deep dive on this topic and hopefully provide you with some really practical tips and advice. In the meantime, if you haven't checked out the Tox course at etmonline.com, please head to the website. We've just launched Module 3, which covers a range of serious medication ingestions, including aspirin, beta blockers and calcium channel blockers, digoxin, lithium, prescribed stimulants, which includes dexamphetamine, lisdexamphetamine and methylphenidate, centrally acting sympatholytics such as clonidine and guanfacine, gabapentinoids, baclofen, and we even include a fantastic section on toxicology procedures, including charcoal and multi-dose activated charcoal, whole bowel irrigation, extracorporeal therapies, including but not limited to hemodialysis, urinary alkalinisation, and high-dose insulin euglycemic therapy, or HIAT. I can tell you for anyone who works in the ED, and particularly for those approaching their emergency medicine fellowship exams, this module is worth it just for the tox procedures section alone. To celebrate the release of Module 3, we've also announced a special discount at ETM Online. If you subscribe to 2 modules, you'll get a 5% discount. If you subscribe to Module 1, 2 and 3 at the same time, you'll get a 10% discount. We've also finished recording and have almost finished production of Module 4, which is the much anticipated bites, stings and envenomation module, featuring a very exciting special guest that I'm sure will blow your minds when it's released. And we'll be sure to announce it on the podcast when it's launched. Thanks for listening, and we'll see you on the next episode.